Hi, this is Greg Friedman, and today I'm going to talk to you about the keys to exceptional documentation in the least amount of time. So some background on me. I've been a chiropractor now for, well, since 1987. I graduated chiropractic school end of 1986. I still see patients a few mornings a week. I'm a second generation chiropractor. My father practiced for 60 years. I became certified back in 2004 as an IME doctor, not so I could screw with chiropractors all day long, but I just had this sneaky suspicion that many of the doctors that were doing reviews and IMEs against us were just making stuff up, but I had no proof, no evidence. So I decided to infiltrate, to become one of them, to figure out if I was right or not. Well, guess what? I was right. Some of the doctors know what they're talking about, but many literally know no more than anybody else does. That's so easy to defeat. Well, ever since then, though, in addition to practicing, I've had opportunities for years to review a lot of records, to perform IMEs, help chiropractors with board complaints and malpractice cases, insurance lawsuits. And the more of these cases I review, the more stories it gives me when I teach seminars. I'm teaching seminars of chiropractors for about 20 years. I love doing this stuff. My whole life has been in and around chiropractic, and now I just want to help chiropractors as much as I can. Well, what are some problems with chiropractic documentation? Well, number one, we may be seeing the patient rather frequently as opposed to a medical doctor who sees them, once every now and then. We may see them every a few times a week or so for a while. And then the problem is our documentation appears to be the same crap, different day. It just doesn't really change. Even if you're using software, many times it's the same crap, different day. It's just legible, but it's the same stuff. We don't really know how to show improvement very well or what kind of improvement. I'm going to show you exactly what we're looking for. No or a crappy treatment plan. A lot of you aren't even doing a treatment plan. You just gave up on it. And those who are doing a treatment plan, at least you're trying, but it's the wrong treatment plan. All right. Improper assessment. I'm going to tell you right now that Medicare is looking for two specific items in the assessment that more than 99% of chiropractors in the United States are simply not doing. And if you're ever audited, you got a big problem. No or ambiguous goals. Many of you aren't even documenting treatment goals, and the few of you that are, they aren't very good. For example, does this sound familiar? Treatment goal number one, reduce pain. Treatment goal number two, improve range of motion. Treatment goal number three, reduce muscle spasms. Doctors, those aren't goals, those are hopes. We need to find one format of documentation that will literally work for everybody. We don't have the time or the energy to wonder about how to document one way for a cash patient and another way for a Medicare patient and a different way for insurance and a different way for workers' comp and yet another way for PI. Who's got time for that? We need to find one format that will work for everyone, one for all and all for one. And it exists, doctors, and I'm telling you, it makes our lives so much easier. I mean, think about a typical medical practice. If you or your patient goes to a medical doctor, what do they do after the staff takes the insurance information? Well, what happens is they take them to this scale, they weigh them, they measure them, they do the vital signs, blood pressure, pulse, respiration, things like that. And then they go in and see the doctor. The doctor asks them a few questions, pokes around a little bit, and then says, let's get some blood work. Let's do urinalysis. What do these have in common? Well, their metrics, their numbers. How does a doctor know if you've gained or lost weight? Metrics, it's the numbers. How do they know if you're running a fever or not? It's the metrics. How do they know if you're improving or not with the prescriptions that they gave you? It's the metrics. They're looking at numbers. And doctors, we've got to think about the same thing. We need to think about with chiropractic, how do we use metrics to show the world how effective we are? Well, use more metrics. Okay, so which metrics are we going to use? Starting with the subjective part of SOAP. First of all, we're going to document each symptom that we're treating. So don't think of it in terms of on a history documenting the patient's chief complaint. We're going to document each complaint, all of them. And a great efficient way to do this is with the use of intake forms, because a lot of the questions that we're going to ask the patient in the history could be asked on paper, and we can send it to the patient ahead of time. In my office, what we do is once the patient calls to make their first visit appointment, we get their email address, or we ask if they have accessibility to the internet, and we can send them to a website, and they can print off this forms from the website, and they're instructed to do this ahead of time bringing in the forms to their appointment already completed. It saves you, the doctor, a ton of time. And we're going to follow this whole thing based on certain metrics. Metric number one, the intensity of pain. Number two, pain frequency. And number three, outcome questionnaire scores for each complaint. All right, so let's talk about pain intensity first. Pain intensity, we could use what's called the verbal numeric rating scale, where we're going to have the patient rate each symptom from 0 to 10, with 0 being no pain, 10 being the worst pain imaginable. But rather than ask the patient to give you a number from 0 to 10, if you want to make it easier on them and you, find out from the patient if they consider their symptom mild, moderate, or severe. Mild is defined as 1 to a 10, 1 to a 3, moderate between a 4 and a 7, severe between an 8 and a 10. So if the patient says their pain is moderate, that tells us that it's between a 4 and a 7. This now, instead of having the patient give you a number between 0 and 10, they simply need to come up with a number between 4 and 7. Much, much easier. Now once we do that on the first visit, after that, I can actually see what they said on the last visit and say, okay, last visit your symptom was a 6. What is it today? Has it changed at all? The patient says, yeah, it's down to a 5 today. All right. We're going to do that for each symptom. It's a metric that we can track very quickly and very easily. Pain frequency is another excellent metric that we can keep track of. In fact, the pain frequency actually adds context to the pain intensity because you know as well as I do that if we just document intensity, that could get stuck pretty easily. Patient's pain is a 7, 7, 7, 7, 7. That isn't showing up very well, is it? But now we could document the patient's frequency of the pain. And you want to use percentages like 5 or 10% increments, 85%, 50%, 25%, and so on. Because that way we can show even small units of change. It's a great way to document that. What you don't want to do, though, is to use the ranges of occasional, intermittent, frequent, and constant. The problem with those ranges, which unfortunately for many of you, that's the most common format of documenting frequency in software right now. The problem with it is that it only shows change when they move to a new category. Well, the patient could be stuck in a category for several months, and that does not help you out. So here's what I did. I designed an intake form that asks all the pertinent questions that we're required to ask, right? All the past health history, the surgeries, prior traumas, family health history, social and occupational, lifestyle, what medications they're taking and why they're taking them, the review of systems. This is 10 different systems, multiple choice. They do a great job of answering these questions. You get a lot of really good information from it. Got my HIPAA notice. Then I've got my symptom form. Okay, patient writes in the symptom number 1 and then they answer those questions. What are those questions? It's the basic OPQRST history, all the stuff that we would ask verbally. Let them do it on paper. And the bottom, we want to also know, did you try anything else for this symptom? Any other treatment? That's a requirement, by the way. If they have a second symptom and a third symptom, they write it in, answer the questions. In Bulletproof EMR, what I do is I'm going to create an incident where I'm going to choose, if I know the date of onset specifically, I'll document it here. If I want to, I'm going to document my name. If I have multiple users especially, I can document what type of patient this is, regular PI or something else. And let's now create a new visit, all right? Today's date, all right? I want this information to appear in the SOAP note. And let's just do one symptom right now. Lower back pain. Let's say the patient said it was on the right side. The intensity was a 7 out of 10, 85% of awake time. Gradual onset. The date pops up automatically if I put in a specific date for the incident. What makes the lower back pain worse? I'm taking this all from the paperwork that the patient already filled out. What makes it better? Again, all from the paperwork that the patient filled out ahead of time. Quality of the lower back pain. I take it from their paperwork. Is it radicular or not? When is it worse? And then the outcome questionnaires. It's critical to use outcome questionnaires to establish measurable functional baselines at the beginning of care. And then I want to document if they had prior treatment or not. The basic information, also from the paperwork, we'll just document surgical and trauma history, family health history, social occupational, again, all taken from their paperwork. This particular patient named Bulletproof is a circus clown. Document the work schedule, the recreational activities. Lifestyle activities, already done on the paperwork. If they're taking medications, I can actually put in the program what medications and why they're taking them, or it defaults to no medications. Review of systems is follows the same direction and flow as the paperwork, and I just default everything to negative. If something's positive that they checked off on the paperwork, you would simply click on it here. And then this is what the beginning part of my SOAP note looks like. I've got a very specific history, all the other information there that took me literally a very, very small amount of time to enter. Okay, what about the objective part of our SOAP notes? Okay, so the first thing we're going to do is document our exam. We'll do our E&M exam first, orthoneuro, and then we're going to think about the part exam. Now, the part exam is really only required by Medicare, but it works great for everybody, and it can be done quickly and easily. So to remind you, the P of part stands for pain and tenderness. We've already documented that as part of the symptoms. Well, now for the objective part of our SOAP note, we can document the A, R, and T of part. The A stands for asymmetry misalignment, and we're going to document specific restricted segments. Now, there's no need to document metrics here, just the specific segments. The R of part is range of motion abnormality, and for this, we can document range of motion measurements at the initial and re-exams if we want to. That's optional. At a regular daily visit, we wouldn't measure range of motion. We could simply document if there's pain in each plane of motion or not. There's no need to document metrics for range of motion at daily visits. The TF part stands for tissue and tone changes, and for this we want to document more specifically the paraspinal muscles. No need for metrics here either, but we could be more specific by saying left, right, or bilateral, levator scapula, rhomboid, trapezius, erector spinae, and so on. So here's how I do it in bulletproof. This is a typical normal orthoneuro exam. These are the things that I examined. Let's say for the lumbar spine, the orthopedic test that we did, heel walk was normal, toe walk was normal, and even straight leg raise was normal. Maybe we did a slump test, and that was negative as well. Dermatomes for this particular patient were normal. Now, if they were abnormal, I would have documented that very clearly as well. Reflexes were normal. Lower extremity muscle strength was normal. Now we get to the part of the exam. The AF part, asymmetry misalignment, all you've got to do here is document the specific segments. That's it. But you have to document. If you're going to be adjusting the spine, doctors, you've got to document what areas were restricted. Same with extremities. If you like to adjust extremities, make sure you are documenting under objective findings what extremities were restricted. You could document posture analysis, gait analysis. Here's a visual assessment of range of motion noting pain only. I'm just checking off where there's increase in pain. What if I want to actually measure range of motion with inclinometers, for example? I'm simply going to measure and enter here the measurements. Let's say it was 26 degrees in flexion and 28 degrees in extension, and left lateral flexion 12 degrees, right lateral flexion 14 degrees. Right? Daily findings for muscle spasms or trigger points. Again, I want to document the specific muscles, left, right, bilateral. And here's what my SOAP notes look like for my exam. Here's my orthoneuro exam. Very straightforward. The AF part, the RF part. Here's my range of motion measurements. There we go. Now we get to the assessment. For the assessment, we need to show this. How is each condition responding since the previous visit? So Medicare wants two things from us, doctors. They want to know how is each condition responding since the previous treatment. And they also want to know the effectiveness of our treatment. So how do we do this? Well, the program will automatically calculate the change in each metric. So for the daily visits, it's going to calculate the change in pain intensity and pain frequency for each treatment that you're documenting. At re-exams, it's going to also calculate automatically the changes in the outcome assessments, whether that's the outcome questionnaires, range of motion measurements, or both. All right. Complicating factors, which may slow the recovery of the patient, are very powerful to have in your notes. And I took these from the CCGPP guidelines. There's three categories of patient characteristics, injury characteristics, and history. And we could take these complicating factors and document them specifically for each condition. That's very, very helpful. In addition, under the assessment, we could document our diagnoses, both the code and the description. Now, some doctors ask me, Greg, what if I have the diagnoses somewhere other than assessment? Is that okay? Yeah, that's fine. It could be as long as it's somewhere, but it's probably best suited under assessment. So here's how we document the assessment in Bulletproof. First visit is going to actually calculate and document guarded as the assessment for each metric and for each condition. Why do we use guarded? Because when we're looking back to the previous visit, there is no previous visit. Now here the program will also, based on the time frame or specific date of onset, it will automatically calculate if this is acute or chronic based on 4 weeks. Even the range of motion measurements, it's going to come up with a metric for the assessment. So the first visit will always be guarded because there's no visit for which to compare. This right here is a Medicare requirement, but I think it's not a bad idea for everybody else. It's where we're documenting any relative or absolute contraindications to dynamic thrust adjusting. Right, that's the verbiage right for Medicare. Diagnosing, I split it up into categories so that we're not having to look at all these diagnoses at the same time. So here's lumbar spine. Pick your diagnoses. There's even an opportunity, if you click on Other at the bottom left, to add in your own diagnoses. And then in my SOAP note, here's what my assessment looks like. I've got an assessment, a metric assessment, not only for each condition, but for each metric for each condition. Here's the verbiage for the dynamic thrust adjusting. And then these are the diagnoses, both code and description. What about a subsequent visit assessment? Let's say the next visit, the intensity went from a 7 to a 5, frequency went from 85% to 50%. Then maybe we did new questionnaires that went from a 48 down to a 33. We go to the part exam and maybe we do new measurements of range of motion. Now we can see what the old measurements were, just put in the new measurements. The 26 went to 38 for flexion. Extension went from 28 to 30. Left lateral flexion went from 12 to 22. Right lateral flexion went from 14 degrees to 18 degrees. We go to assessment, watch what happens. The program automatically calculated the metric improvement or change in each metric, right? In each metric. So it's going to calculate for us that improvement or not, even for each measurement. So I'm going to have multiple assessments. I like telling the patient how they're improving. They really get a kick out of that. Here's what the SOAP note looks like when we talk about the assessment. So now we have our new metrics. The assessment, see this, tells us what the change was automatically. Now we get to the P of SOAP, or the plan. The first part of plan is what treatment was performed. If we're doing spinal extremity adjustments, we should be able to pull in the software the restricted segments that we already documented under objective findings. When we're doing modalities, we should be able to have in the SOAP notes automatically the requirements of documenting for that. Therapeutic procedures like manual therapy and therapeutic exercise, the software will pull in automatically those objective findings that justify the treatment. Here's how that looks. So let's say we go to treatment performed, treatment plan, spinal adjustments. Click on that. You see the highlighted buttons are the restrictions that were already documented before under objective findings. Extremities, same idea. It already brings in automatically what I documented under objective findings. All these different modalities are in the program. Let's say we do manual therapy. If we do manual therapy, like myofascial release, for example, it brings in automatically the muscles that we documented. We simply have to document the time and what exactly did we do for the manual therapy. Therapeutic exercise, it brings in the areas of painful range of motion. We just have to document the time. If we want to document home care, if you send the patient home with exercises, we're recommending they do it twice a day, for example. We document that. Response to treatment, either they responded well or something bad happened. Document that. And my SOAP notes will look like this. So I've got my spinal adjustments, extremity adjustments, manual therapy, therapeutic exercise, home care, response to treatment. That took me seconds to document, doctors. What about the other plan? The other plan is where are you going with this? Treatment frequency and duration, treatment goals, metrics for pain intensity, pain frequency, outcome assessments. You want goals for that to show up. It's got to be measurable. So the intensity and frequency are daily, outcome assessments at re-exams, and as the goal is achieved, we move the finish line. All right? We keep moving the finish line, keep moving the goals as we achieve a goal. Medicare requires that we document what objective measures will be used to determine treatment effectiveness. They want to know what we're going to measure. What function will we measure? Here's how we do that. Okay, automatically the goals are set. I did none of this. The software did it for us. It calculated the goals for each condition based on 30% improvement for each metric within a 4-week trial of care. Automatically done. We could document frequency. Reevaluation we'll do in, let's say, 2 weeks. And we're going to do the verbal numeric rating scale and the outcome questionnaires. My SOAP note for that looks like this. It has the goals for each metric, the reevaluation, frequency. I want our documentation to be so exceptional, so bulletproof as much as possible, in the least amount of time, with the least amount of effort, and it's got to be affordable, and I mean really affordable. So it's only $30 a month, and this is server-based. It's not on the cloud, it's in your computer. And one of the problems I have with the cloud is too many big companies get hacked in their cloud. And number two, if you're using or looking at a cloud program, I want you to ask the company, when you discontinue using their cloud-based program, how will you get the records? That is a very important question to ask because either some of them will charge a fortune for you to get the records or they simply won't be able to get them to you unless you continue to pay to have access to it. That sucks. All right. So I want this to be on your server and you back it up. I back up mine to a cloud program, but I have it on my server. This $30 a month. That includes all updates and support. There is a one-time cost of only $1,497. One time, $1,497. If you have partners in your clinic or you have associate doctors, for each of them it's just an additional $499 per doctor. That way they're not all paying the $1,497. All right, that's affordable. Everyone can do it. You want to come to one of my seminars that understand really how to document? Come to my website at gotdocumentation.com and you'll see my schedule. I'm all over the country. I do between 25 and 30 weekend seminars a year, plus the occasional convention. I always speak at Parker in Dallas and Parker in Vegas. I love doing those. So feel free to come out, check out my schedule. Doctors, I want the profession to be bulletproof. It's so easy, it can be so quick, and it's so affordable. We can do it. All right. And the more bulletproof we are, the more we show as a profession how effective chiropractic care is, we can change the world. If you have any questions, doctors, feel free and email me at Dr. Greg, and there's 2 G's at the end of Greg, Dr. Greg at thebulletproofchiro.com.